Knee anatomy. The tibia is commonly called the shin bone and runs from the knee to the ankle. The top of the tibia is made of two plateaus and a knuckle-like protuberance called the tibial tubercle. Attached to the top of the tibia on each side of the tibial plateau are two crescent-shaped shock-absorbing cartilages called menisci, which help stabilize the knee. The tibia is the medial and the primary weight-bearing bone. Bony anatomical locations include the tibial tuberosity, which can be palpated in the front middle part of the knee, the tibial plateau, which is a little harder to palpate but can be felt at the joint line, and the shaft, which is triangular in shape. You can run your fingers down the shaft of the tibia. It may be bumpy from running into things as you grow up. The fibula is a long, thin bone in the lower leg on the lateral side and runs along the side of the tibia from the knee to the ankle. The fibula is lateral and takes about The fibula accounts for about 0 to 12% of weight bearing depending on the activity. The bony anatomical locations for the fibular head include the fibular head. Once you have found the tibial tuberosity, palpate to the lateral side. It may stick out on certain individuals. The femur is commonly called the thigh bone. It is the largest and longest and strongest bone in the body. The round knobs at the end of the bone are called condyles. The cylindrical shaft is bowed outward. Bony anatomical locations include the head and neck, greater and lesser trochanter, medial and lateral condyle, and medial and lateral epicondyle. This is a picture of the anterior and posterior views of the femur with different landmarks. The patella is also known as the kneecap or the knee pan, is a thick circular triangular bone which articulates with the femur, the thigh bone, and covers and protects the anterior articular surface of the knee joint. The patella is found in humans, the patella is the largest sesamoid bone in the body. Babies are born with a patella of soft cartilage which begins to ossify or harden into bone at about 3 years of age. The patella is a sesamoid bone, roughly triangular in shape, with the apex of the patella facing downwards. The apex is the most inferior or lowest part of the patella. It is pointed in shape and gives attachment to the patella ligament. The primary functional role of the patella is to extend the knee. The patella tendon enhances the mechanical efficiency of the quadriceps muscle. The patella increases the leverage that the tendon can exert on the femur by increasing the angle at which it acts. The patella protects the femoral condyles and improves the aesthetic appearance of the knee, making it more pleasing to look at. It is attached to the tendon of the quadriceps femoris muscle, which contracts and extends or straightens the knee. The patella is stabilized by the insertion of the horizontal fibers of the vastus medialis and by the prominence of the lateral femoral condyle, which discourages lateral dislocation during flexion. The retinacular fibers of the patella also stabilize it during exercise. Our knee is the most complicated and largest joint in the body. It is also the most vulnerable because it bears enormous amount of weight and pressure loads while providing flexible movement. When we walk, our knee supports 1.5 times our body weight. Climbing stairs is about 3 to 4 times our body weight, and squatting about 8 times. The knee anatomy is about the structure of the knee, that is, the parts that make up the knee. The knee is one of the most important joints of our body. It plays an essential role in movement related to carrying the body weight in horizontal, which would be running and walking, and vertical or jumping directions. The knee is a modified hinge type synovial joint. The joint is bathed in synovial fluid, which is then contained inside a synovial membrane called the joint capsule. The knee joint connects to the femur, our thigh bone, and the the knee joint connects to the femur and to the tibia. There are two joints in the knee, the tibiofemoral joint, which joins the tibia to the femur, and the patellofemoral joint, which joins the kneecap to the femur. These two joints work together to perform a modified hinge joint, which allows the knee to bend and straighten, but also rotate slightly from side to side. The ligaments surrounding the knee joint offer stability by limiting movements, and together with several menisci and bursa, protect the articular capsule. The menisci serve to protect the ends of the bones from rubbing on each other and effectively deepen the tibial sockets into which the femur attaches. They also play a role in shock absorption and may be cracked or torn when the knee is forcefully rotated or bent. The knees have a screw-home rotation that allows for full knee extension and flexion. There is an observable rotation in the knee during flexion and extension. During the last 30 degrees of knee extension, the tibia in open kinetic chain or the femur in closed kinetic chain must externally or internally rotate respectively about 10 degrees. There is an observable rotation in the knee during flexion and extension. During the last 30 degrees of knee extension, the tibia in open kinetic chain or the femur in closed kinetic chain must externally or internally rotate respectively about 10 degrees. That may not seem very significant, but this rotation is important for the healthy movement of the knee. Whether it is tibial on femoral rotation, as in open kinetic chain exercises like an Whether it is tibial on femoral rotation, as in an open kinetic chain exercise such as the leg extension machine, or the femoral on tibial rotation, as in a closed kinetic chain exercise like a squat, rotation must occur to achieve full extension and then full flexion from full extension. This is due to several factors, including the shape of the medial femoral condyle. The condyles on the femur are shaped a bit differently than those elsewhere in the body. According to research, the articular surface at the end of the bone where the two bones join to allow movement on the medial femoral condyle has a 30-degree lateral curvature. This curvature allows the tibia and the femur to follow this curve with tibial on femoral rotation as well as femoral on tibial rotation. The lateral pull of the quadriceps is a factor in the lateral rotation during the later phase of extension. The quadriceps insert onto the tibial tuberosity via the patella tendon. When contracted, the quadriceps cause an anterior translation of the tibia on the femur. This creates a passive tension on the anterior cruciate ligament, which contributes to external rotation. This passive tension helps stabilize and extend the knee by resisting excessive anterior tibial translation. This passive tension helps stabilize the extended knee by resisting excessive anterior translation of the tibia or excessive posterior translation of the femur. In order to unlock the knee from extension, the popliteus muscle must work to initiate internal or external rotation. The tibia must internally rotate slightly to allow for knee flexion in an open kinetic chain, and the femur must externally rotate for knee flexion in a closed kinetic chain. This mechanism of rotation contributes to proper movement at the knee. The patellofemoral joint is where your patella or kneecap and the femur meet at the front of your knee. The underside of your kneecap sits in a groove within your thigh bone called the patellofemoral groove. Within this groove, the kneecap mostly moves lengthwise, but it has some side-to-side movement as well and can tilt and rotate in addition. When you contract the quadriceps, or the muscles of your thigh, they pull on the quadriceps tendon that attaches to the kneecap or patella. This makes your knee straighten. Two other thigh muscles help keep your kneecap in the frontal patella in the femoral groove during this motion. the vastus medialis obliquus, and the vastus lateralis. They're located on the inside and the outside of your thigh. The patellofemoral joint is a modified plain synovial joint. The joint capsule of this joint is connected with the capsule of the tibiofemoral joint. The way that the patella tracks within the patellofemoral joint can mean the difference between having a painful knee and not. The patella is pulled by the quadriceps muscle group and slides up and down during knee movements. During knee flexion, the patella slides downward on the femur. During knee extension, the patella slides upward on the femur. The primary knee ligaments include the medial collateral ligament, lateral collateral ligament, anterior cruciate ligament, and posterior cruciate ligament. The knee works similarly to a rounded surface sitting atop a flat surface. The function of the ligaments is to attach the bones to bones and give strength and stability to the knee, as the knee has very little stability on its own. Ligaments are strong and tough bands that are not particularly flexible. Once stretched, they tend to stay stretched, and if stretched too far, they may eventually snap. The medial collateral ligament attaches to the medial side of the femur to the medial side of the tibia and limits sideways or valgus motion of the knee. The MCL or medial collateral ligament has two layers. The superficial layer is a strong, broad strap, and the deep layer is a thickening of the joint capsule and blends with the medial meniscus. The lateral collateral ligament attaches to the lateral side of the femur. The lateral collateral ligament attaches the lateral side of the femur to the lateral side of the fibula and limits sideways or varus motion of your knee. The LCL, or lateral collateral ligament, is a cord-like structure which runs from the lateral epicondyle to the fibular head. Some people are able to palpate their lateral collateral ligament if they put one foot up on the thigh of the other leg in a figure 4 position and then palpate around the joint line. It feels almost like a pencil that sits. The LCL feels kind of like a cord-like structure or even a pencil which runs from the lateral epicondyle to the fibular head. The medial collateral ligament and the lateral collateral ligaments have two major functions each. The medial collateral ligament resists valgus force and provides medial stability. It also resists external rotation of the tibia. The lateral collateral ligament resists varus force and provides lateral stability and also resists external rotation of the tibia. The anterior cruciate and posterior cruciate ligaments are the primary rotary stabilizers of the knee. They crisscross one another within the joint cavity in an oblique fashion. The anterior cruciate ligament attaches the tibia and the femur in the center of your knee. It is located deep inside the knee and in front of the posterior cruciate ligament. It limits rotation and forward motion of the tibia. The ACL, or anterior cruciate ligament, is the most frequently injured ligament in the knee. The posterior cruciate ligament is the strongest ligament and attaches the tibia and the femur. It is also deep inside the knee, behind the anterior cruciate ligament. It limits the backward motion of the knee. The PCL, or posterior cruciate ligament, is the strongest ligament in the knee. The anterior cruciate and posterior cruciate ligaments are each made up of multiple bundle structures. The ACL originates deep within the notch of the distal femur. Its proximal fibers fan out along the medial wall of the lateral femoral condyle. There are three bundles of the ACL, the anterior medial and the posterior. There are three bundles of the ACL, the anterior medial, the posterior lateral, and the intermediate bundle. Each are named according to where the bundles insert onto the tibial plateau. The ACL provides 85% of the restraining force of the anterior tibial The ACL provides 85% of the restraining force to the anterior tibial displacement at 30 degrees and 90 degrees of knee flexion. The PCL, or posterior cruciate ligament, connects to the posterior The PCL connects the posterior intercondylar area of the tibia to the medial condyle of the femur. This configuration allows the PCL to resist forces pushing the tibia posteriorly relative to the femur. Although each PCL is a unified unit, they are described as separate anterior lateral and posterior medial sections based off of where each section's attachment site and function. During knee joint movement, the PCL rotates such that the anterior lateral section stretches in knee flexion but not in knee extension, and the posterior medial bundle stretches in extension rather than flexion. The function of the PCL is to prevent the femur from sliding off the anterior edge of the tibia and to prevent the tibia from displacing posteriorly on the femur. The posterior cruciate ligament is located within the knee. For both the anterior and posterior cruciate ligaments, each of the bands are taut through varying portions of knee range of motion, and thus may be injured depending on which range of motion the knee is hidden during injury. The anterior cruciate ligament and posterior cruciate ligaments have vital functions in stabilizing anterior and posterior translation of the knee. The function of the anterior cruciate ligament is to resist anterior tibial translation, resist internal and external rotation of the tibia, and resist hyperextension. The function of the posterior cruciate ligament is to resist posterior translation of the tibia and resist external rotation of the tibia. The ends of the bones that touch each other in a joint are covered with articular cartilage. It gets its name from articular because when the bones move against each other, they are said to articulate. Articular cartilage is white, smooth, and a fibrous connective tissue that covers the ends of bones and protects the bones as the joint moves. It also allows the bones to move more freely against each other. The articular cartilage of the knee covers the ends of the femur and the top of the tibia and the back of the patella. In the middle of the knee are menisci. They're disc-shaped cushions that act as shock absorbers. In a healthy knee, the rubbery medial and lateral menisci menisci is the singular of meniscus, are cartilage that absorb shock In a healthy knee, the rubbery medial and lateral menisci, meniscus is the plural of menisci, are cartilage that absorb shock and the side forces placed on the knee. Together, the menisci sit on top of the tibia and help spread the weight-bearing force over a larger area. Because the menisci are shaped like a shallow socket to accommodate the end of the femur, they help the ligaments in making the knee more stable. And also because the menisci also help spread out the weight-bearing joint across. Because the menisci help spread out the weight-bearing joint across the joint, they help keep the articular cartilage from wearing away at friction points. The medial meniscus is made up of fibrous, crescent-shaped cartilage. and attaches to the tibia on the inside of the knee. The medial meniscus is larger and is shaped in a C or crescent-shaped. It is thicker posteriorly than it is anteriorly. The lateral meniscus is made of fibrous, crescent-shaped cartilage. The lateral meniscus is much smaller and more shaped like an O. It is equal thickness throughout. Each meniscus has three parts: an anterior horn, a body, and a posterior horn. Any one of these three parts may be injured during a meniscus injury. The menisci are not completely vascularized. The menisci have three different vascular zones. The red zone has about a 10 to 30% vascularization. The red, white, or pink zone has minimal blood supply, and the white zone is avascular or has no blood supply. Only injuries which occur in the red zone have a chance of healing. Injuries which occur in the white zone usually result in removal Injuries which occur in the white zone usually result in removal of the menisci as the healing process is ineffective without blood flow. Other structures which support and stabilize the knee include the lateral and medial patellofemoral ligament. The lateral patellofemoral ligament prevents medial patellar displacement. The medial patellofemoral ligament prevents lateral patellar displacement. The lateral and medial retinaculum function the same way as the patellofemoral ligaments do. The only difference is they run just a little bit more oblique than do the patellofemoral ligaments. Altogether, these structures help hold the patella in place. The bursae of the knee are fluid-filled sacs and synovial pockets that surround and sometimes communicate with the joint cavity. They are thin-walled and filled with synovial fluid. They represent a weak point of the joint, but also produce enlargements to the joint space. There are 5 main bursae of the knee. The suprapatellar bursa is located between the anterior surface of the lower part of the femur and the deep surface of the quadriceps femoris. It allows for movement of the quadriceps tendon over the distal end of the femur. The prepatellar bursa, which is located between the patella and the skin, results in housemaid's knee when inflamed. It allows the movement of the skin over the underlying patella. The deep infrapatellar bursa, which is between the upper part of the tibia and the patellar ligament, allows for movement of the patellar ligament over the tibia. The superficial infrapatellar bursa is located between the patellar ligament and the skin. Lastly, the Pes Anserine bursa, which is located between the medial tibial The Pes Anserine bursa, which is located between the medial or tibial collateral ligament and the tendons of the sartorius, gracilis, and semitendinosus, which are also known as the Pes Anserinus. Multiple other bursae exist in the knee. These are the most commonly injured, though. What haven't we talked about? Fat pads. Unfortunately, the knee actually has fat pads, the suprapatellar fat pad and the infrapatellar fat pad. Fat pads can be damaged when they get pinched in between the bony structures. The infrapatellar fat pad is the infrapatellar fat pad is the fat pad that gets pinched most frequently is the infrapatellar fat pad. This is also known as Hoffa's fat pad. Fat pads are used to separate tissues and protect tissues, so it protects the knee joint from injury. No muscles really encompass the knee. Rather, many muscles affect the knee by crossing the joint. The anterior muscles include the quadriceps muscle group, which is comprised of the rectus femoris, vastus lateralis, vastus medialis, and vastus intermedialis, which form the quadriceps tendon or patella tendon and pass around the patella. They become the patellar tendon, patellar ligament, and insert onto the tibial tuberosity. It also includes the individual muscles of the sartorius and the gracilis. The lateral muscles include the tensor fascia lata, the IT band. The lateral muscles include the tensor fascia lata and the IT band. Some texts identify Some references identify the iliotibial. Some textbooks identify the iliotibial band as a muscle. Others refer to this as a fibrous reinforcement of the tensor fascia lata muscle. This can also be known as a longitudinal fibrous reinforcement. The part of the iliotibial band which lies beneath the tensor fascia lata is prolonged upward to join with the lateral part of the capsule of the hip joint. The tensor fascia lata effectively tightens the iliotibial band around the area of the knee. This allows for bracing of the knee, especially in lifting of the opposite foot. The iliotibial band inserts on Gerdy's tubercle, which can be palpated as a bump just lateral to the tibial tuberosity, halfway between the tibial tuberosity and the head of the fibula. The iliotibial band provides lateral knee stability. The posterior muscles include the hamstring muscle group, which is comprised of the biceps femoris, semitendinosus, and semimembranosus, and the popliteus muscle, which is instrumental in unlocking the knee when weight-bearing. The medial muscles include the Pes Anserine group. The tendons from this group can be palpated just medially to the tibial tuberosity. The Pes Anserine is made up of the sartorius, gracilis, and semitendinosus. I was always taught that this is the Sargent muscle group, as when you take the first letter of each of the muscles going from anterior to posterior, it spells SGT, or the Army's abbreviation for sergeant. The Pes Anserine tendon also has a bursa that sits beneath the tendon. The Pes Anserine muscles are responsible for knee flexion and tibial internal rotation. This is an easy picture to remember the palpations of the knee. By placing your hand on your knee, your right hand on your right knee, you will find 5 easy palpation locations. The thumb is the medial collateral ligament. The index finger is the Pes Anserine, which is made up of the sartorius, gracilis, and semitendinosus muscle. The middle finger is the tibial tuberosity, which is the insertion point for the quadriceps muscle via the patella tendon. The ring finger is Gerdy's tubercle, which is the insertion point for the iliotibial band. And the pinky finger is on the lateral collateral ligament. The degree of the Q angle is determined by measuring. The Q angle is also known as the quadriceps angle. The degree of the Q angle is determined by measuring 2 lines superimposed on the lower extremity. One line begins on the tibial tuberosity and continues in a superior direction through the midpoint of the patella. A second line connects the anterior superior iliac spine with the midpoint of the patella. Normally for men, this is 13 degrees, and for women it's somewhere around 18 degrees. Women typically have higher Q angles due to their naturally wider pelvis. Measurements can be taken either standing or lying down. If measured lying down, the angle will typically be 1 to 3 degrees lower. A high Q angle often results in maltracking of the patella. That is, it does not track over the front part of the knee joint as it should. Over time, this can cause microtrauma to the cartilage and the rear portion of the patella, which causes pain, often known as anterior knee pain, patellofemoral pain, or chondromalacia patella. Having overpronated feet or walking on the medial portion of your feet also places additional strain on the quadriceps angle due to the excessive internal rotation of the tibia. Measuring the Q angle helps identify and measure the line of pull of the patella tendon and the resultant forces that are being placed on the patella.